The effectiveness of phototherapy is dependent on the intensity of phototherapy administered, which is the irradiance of the unit you are using, and the surface area of the infant exposed to phototherapy. So if you have a double-sided, one at the bottom and one at the top, it's going to work better than having a single-sided. Having 3 or 4 units around the baby simply, even though they are high irradiance, doesn't increase the surface area, so it's not going to really change the effectiveness of your phototherapy. The general approach is to provide intensive phototherapy to as much of the infant surface area as possible. So the AAP and other bodies do not really recommend single phototherapy or mild phototherapy. So many of the LED units come with single, double, triple, etc. Go for the intensive phototherapy as it will shorten the duration. The bilirubin will respond quicker and make it more effective. There is no need for a distance measure which we used to use before. There is hardly any risk of overheating. So a safe distance where you should not be bumping the baby on the unit, and you should be taking precautions to move the unit away when you are going to lift the baby for feeding and so on. So all this should be attended to. The iPad should be covering the baby, but apart from that, the closer the unit, the better. And if you are positioning more than one unit, think carefully about how to position them so to effectively increase the surface area. Now we have bilirubin drums which are quite effective as well, and the hospital should have a system where they monitor the irradiance on a regular basis, change the bulbs on the right timing and so on. So the advantage of intensive phototherapy is that it can reduce quickly the TSB and should shorten the duration of treatment. Treatment duration obviously affects the separation of the mother and the baby and increases the anxiety level. So there is no evidence to show that intensive phototherapy is more harmful than normal phototherapy. The recommended phototherapy thresholds are far below those at which overt acute bilirubin neurotoxicity or kernicterus occurs. So this is another safety point, that even though we are having a treatment threshold, it's not anywhere near the bilirubin neurotoxicity, so you don't need to panic. And one important point about the intensity of phototherapy and the duration of treatment is it's different for the extreme premature babies. So there the skin is very thin, you may have changes at the tissue level, and we should be careful about unnecessarily using intensive phototherapy in the smaller babies. So a less intensive phototherapy for a longer duration, these are babies who are going to be in NICU anyway, may be safer. Of course, this is not the scope of this guideline, this is just an additional point I'm adding. So we will be looking at the next 2 figures, one chart for babies with no neurotoxicity and a separate chart for babies with neurotoxicity. So this makes it a very positive action because the doctor has to look at the neurotoxicity risk factors and it will not be missed for any reason. Intensive phototherapy is recommended at the total serum bilirubin thresholds in the charts on the basis of gestational age. So you have separate lines for gestational age based in the previous. The preterm babies were put in the high risk, and hyperbilirubinemia neurotoxicity risk factors determine which chart you use, and the age of the infant is ours on the chart. So this is the new chart for babies without neurotoxicity risk factors. You have different lines for 35, 36, 37, 38, 39 and more than 40. In this aspect, it's better than the NICE guidelines because the NICE guidelines clubs all the babies above 38 weeks in one go. And so it ends up over treating some of the relatively or under treating some of the 38, 39 weekers. So this is a very positive change for 2 reasons. As I mentioned, you are clearly differentiating the neurotoxicity risk factors by using a totally different chart. So if you're using the wrong chart, then God help you. A comparison of the previous chart which was used, and this is the high risk, medium risk and low risk. Obviously we were clubbing the premature babies and the term babies with neurotoxicity risk factors according to the level, and this is more clear cut, and as we can see here, the treatment thresholds overall are not much different, so it won't make a huge difference. Of course, it makes it safer for the smaller babies where you start the treatment at a lower threshold, and also it may reduce over treatment in the slightly bigger babies as the chart keeps going up with the gestation. So this is the chart with one or more hyperbilirubinemia risk factors which we defined earlier. You may need to consider measuring the serum albumin at this stage and also to look at blood group DAT and G6PD. Of course, if you're sending the newborn screening, you don't need to necessarily repeat the G6PD test because it wouldn't change your approach to treatment. Where there is a surprise element, the jaundice comes suddenly, you may have to do that, and of course, monitoring is important. This part we already covered previously. So the infants born at more than 38 weeks are grouped together in the figure 3. So you can see here that you don't have 39 and 40 separately, all are together. So even though their treatment thresholds are different, there is no clear evidence that the neurotoxicity happens at a higher level for the more mature baby. So it's better to be safe and club them together. The direct bilirubin or conjugated bilirubin should not be deducted from the total serum bilirubin when using the phototherapy chart, and home phototherapy is considered in some situations. There is a separate section on home phototherapy, but I'm not discussing in detail because in Middle East and in India, for example, home phototherapy is not likely to be followed anytime soon. So some babies have persisting jaundice, and it can be at a fairly high level as well. So there are infants 7 days or older with the persistently elevated bilirubin close to the phototherapy threshold, and this may be prolonged indirect hyperbilirubinemia. Most of these babies have breast milk jaundice. You can review my previous video on breast milk jaundice as well. Other causes include hemolytic jaundice, hypothyroidism, extravascular blood collection, pyloric stenosis, Gilbey syndrome, and Crigler-Najjar syndrome. So if it continues despite your interventions, you may consider any of the other syndromes. Of course, in these cases also, eliminating breast milk or adding formula is a consideration only to reduce the risk of needing phototherapy persistently. However, it's not an essential part. If the bilirubin stays below the phototherapy level, the only problem is the need for repeated monitoring. You don't need to monitor it that frequently if the trend is stable, but you do need to bring them up every 1 to 2 days to make sure it doesn't exceed the treatment level. If it does exceed the treatment level, you treat them according to the chart. Home phototherapy is a consideration where it is particularly prolonged, especially in the Crigler-Najjar syndrome. You should remember that in type 2 Crigler-Najjar, there is a role for phenobarbital, which can induce the liver enzyme. So, monitoring the infants receiving phototherapy. For hospitalized babies, bilirubin should be measured within 12 hours after starting the phototherapy. The timing of the initial bilirubin measurement after starting phototherapy and the frequency of bilirubin monitoring during phototherapy should be guided by the age of the child, the presence of hyperbilirubinemia neurotoxicity risk factors, bilirubin concentration, and the TSB trajectory. So you would base it on the overall risk factors. TCB measurements on the skin exposed to phototherapy tends to underestimate the TSB. Even if you put a patch, I have tried it in different units, and the patch does estimate in some babies, but essentially it's easier to do a gas serum bilirubin than to put a patch and monitor. Of course, once you stop the phototherapy after 6 to 8 hours, you can start relying on the TCB as a trend again. So what investigations need to be done in the jaundice babies? So for babies receiving phototherapy, measure the hemoglobin concentration, hematocrit, and complete blood count to assess for the presence of anemia and to look for baseline in case of severe anemia developing. Evaluate the underlying causes of hyperbilirubinemia in the infants who require phototherapy by obtaining a direct Coombs test in the infants whose mother had a positive antibody screen or where it is unknown, or whether the mother is blood group O regardless of the RH status. So G6PD should also be measured in any infant with jaundice of unknown cause where the bilirubin increases despite intensive phototherapy, where the bilirubin increases suddenly or increases after an initial decline, or who requires escalation. So any atypical presentation, you should consider G6PD, and if there is a family history as well. Remember that G6PD is an X-linked recessive condition and boys are more severely affected. I discussed earlier about the G6PD in the newborn screening. So if you are sending it and you get the results by 3 to 4 days, you don't need to repeat a lab test. Of course, if you are strongly suspecting the G6PD and it comes normal, you may consider repeating it after 3 months because the young RBCs tend to have more of the enzyme. So the decision to discontinue phototherapy is based on balancing the desire to minimize the exposure and separation of the mother and infant against the desire to avoid a rebound in the bilirubin. So obviously there is no necessity to keep the baby in hospital for checking for the rebound, but where the risk of rebound is high, you may prefer to keep them in for a day if the parents don't want readmission, or you have to bring them earlier to the clinic. So rebound is defined as the bilirubin concentration reaching a phototherapy threshold for the infant age within 72 to 96 hours of discontinuing phototherapy. So phototherapy eliminates the bilirubin that's present under the skin, and so there will be redistribution after you stop the phototherapy, and there will be some rebound in all the babies, but the significance of the rebound is what matters, and the definition includes 72 to 96 hours. Obviously it precludes keeping them in hospital for that long. Discontinuing phototherapy is an option when the bilirubin has reduced by at least 2 mg% below the hour specific threshold at the time of initiation of phototherapy. So this is a reasonable level to stop, and if you continue phototherapy for longer as well, it's not harmful, but it doesn't serve as much purpose, because it's better to send the family home even for cost and insurance purposes. A longer period of phototherapy is an option if there are risk factors for rebound hyperbilirubinemia. As we will see next, it's mainly gestational age less than 38 weeks, age of the baby less than 48 hours at the start of phototherapy, and presence of hemolytic disease. So if these factors are there, you would be either extending the stay, waiting for the repeat bilirubin after 8 hours or so, or bring them within a few hours to the follow-up. The timing of follow-up after the discontinuation of phototherapy should be based on the risk of rebound. Except in specific circumstances, at least 12 hours should be given, so you don't want to repeat it very soon unless there is a risk factor, and preferably 24 hours should elapse to allow sufficient time for the redistribution to happen and to demonstrate whether there is rebound or at least a risk of rebound, because as I said, it can continue increasing for next 2-3 days as well. And that one measurement at the clinic level may not be enough. If you see an increasing trend but it is below the treatment level, you may need to bring them back at 24-hour intervals to the clinic. So it's very important to have a clear system of follow-up in the clinic, having an arrangement where the parents don't have to wait long, where they don't need to mingle with other patients with infectious disease, for example. So you need to plan your stream in the outpatient clinic to suit these babies. And remember, most of these mothers are really tired. They're having a new baby who is just learning to feed, sleepless nights. So you have to be really considerate in the way we plan the follow-up. It's an option to measure the transcutaneous bilirubin instead of TSB if it has been at least 24 hours since the phototherapy was stopped. I mentioned earlier about the use of the patch during phototherapy, so that is more inconclusive, but this is definitely easier. So if the bilirubin is not that high, you can avoid the blood test at that stage. And infants who exceeded the phototherapy threshold during the birth hospitalization and received phototherapy before 48 hours, had a positive DAT or had known or suspected hemolytic disease, and also the baby is less than 38 weeks gestation, should have the TSB measured 6 to 12 hours after phototherapy discontinuation. So it is this group of babies where we would keep them for a few more hours after stopping phototherapy before we discharge, and then depending on the rate of increase, you can decide the next follow-up. Escalation of a care is a very critical concept where the bilirubin is coming at or close to the exchange level. So it refers to the intensive care that the babies with elevated or rapidly rising bilirubin concentration need to prevent the need for an exchange transfusion and possibly to prevent kernicterus. Escalation of care threshold is 2 mg/dL below the exchange transfusion threshold. The exchange transfusion threshold in the first 24 hours is in a dotted line. So if it is not really too high levels, you can monitor it, especially if there is no risk factor, but obviously it's better to stick with the guideline and follow the threshold. The direct reacting or conjugated bilirubin value should not be subtracted, similar to the treatment decisions for phototherapy when you are determining treatment. Initiating escalation of care is a medical emergency because exchange transfusion is designed to prevent brain injury. So if you're reaching as close to that, you're not far from a brain injury situation. Escalation of care starts from the time the infant's TSB result first mandates starting escalation and ends with the TSB is below the escalation of care threshold. So this is a medico-legal risk, so please document clearly all the times involved. These infants are optimally managed in an NICU, though if you have a drum phototherapy that is delivered in the ward with good supervision, you can monitor at least for the first level after you start the phototherapy if it is the first level that you are doing. Urgent transfer to the NICU that can perform an exchange transfusion is important. If you are in a hospital where you manage such babies in the ward with drum, the NICU should be aware and the preparation for exchange should be ongoing, even if you keep the baby in the ward for the next 4 hours when you are awaiting the bilirubin levels 2 to 4 hours. Intensive phototherapy and intravenous hydration should be initiated and continued when it's approaching the exchange level as well. So we can either start it immediately or after the first 2-hour repeat. If it is coming down, you may not need intravenous hydration. If it's going up, you need intravenous hydration. So that's an individualized practice that you would consider. But again, don't take any risk in these babies because they are close to the exchange level. and the higher the level of bilirubin, the higher the risk of neurotoxicity. That's why you can be a little bit flexible, in my view, in the first 24 hours or so, because the lines are not that defined, and many more babies would have, because the levels are quite low, and it's very unlikely bilirubin neurotoxicity happens at that level. It's more a trend that if it continues, these babies would cross the potential, but they're far below the level when the bilirubin toxicity would happen. So I hope this point is clear. Don't be confused by it. It's just that you have a little more leeway in the first 24 hours compared to the rest of the time when the bilirubin is really quite high. For infants requiring escalation of care, blood should be sent stat for total and direct reacting serum bilirubin, complete blood count, serum albumin to put them in the risk group, and rest of the serum chemistries and type and cross match for the exchange preparation. Infants requiring escalation of care should receive IV hydration and emergent intensive phototherapy, and neonatologist should be consulted and urgent transfer to a unit with an ICU if you don't have that facility yourself. The TSB should be measured at least every 2 hours. So this is important to note, because they want it every 2 hours from the start of the escalation until the escalation of care ends. So as we defined here, so it ends when the TSB is below the escalation of care threshold. So the bilirubin has to come 2 blocks below the exchange transfusion cutoff for that age. So this is a flow chart indicating this. So the starting point is when the TSB exceeds escalation of care level, and is the baby at appropriate location. If they are not, contact the NICU, arrange for transfer. In addition, start intensive phototherapy and peroral or IV hydration during the transfer. If they are already in a good unit who can do the exchange, then you send the stat labs as we discussed, notify the blood bank, measure the bilirubin at least every 2 hours, and intensive phototherapy and peroral or IV hydration and immunoglobulin therapy and bilirubin albumin measurement options can be considered. Acute bilirubin encephalopathy or latest TSB is above, then urgent exchange transfusion should be done. If the baby doesn't meet the exchange level, you can continue intensive phototherapy and hydration and measure every 2 hours till you de-escalate. In terms of hemolysis, you also have end-tidal carbon monoxide measurements. Most of the units do not have that, and that's an indirect marker for hemolysis. These are the exchange transfusion charts, 2 different charts, one for babies with no risk factors for neurotoxicity, and you have for 35, 36, 37 and more than 38. So again, all the babies more than 38 weeks are clubbed together because there is no evidence that they tolerate the neurotoxicity better. And you can see here for a term baby 38 weeks, exchange is around 27 mg/cent by day 3, day 4. And you can see what I mean. In the first 24 hours for these babies, even a level of 22, 21, for example, and in the first 6 hours, even a level of 16 would be indicating exchange transfusion. So obviously they have revised these levels. It's better than the previous charts as well in terms of the number. It has been slightly pushed up, which reduces overreaction. This is the one with neurotoxicity risk factors, again 35, 36, 37 and more than 38 weeks. So they don't really discuss babies under 35 weeks, and most of us follow the NICE UK charts where we have separate charts for the babies for each gestation from 23, 24 weeks onwards in the NICE UK charts. For the babies above 35 weeks, the AAP charts are better. Most of us are using the Billy tool, for example. I've not checked if it has been updated, but we should be watching for the updated version. Until then, have these charts readily available in our mobile phone and printouts in the unit as well. So one more point about the exchange transfusion is that we should be targeting 40% hematocrit so that there is more albumin and less red blood cells which can bind the bilirubin better, because the purpose of exchange transfusion is for the bilirubin to be bound by albumin and removed when you are removing it. IVIG is not clearly evidence-based yet, but where you have isoimmune hemolytic anemia with the positive DIT and the bilirubin reaches or exceeds escalation of care threshold, you consider 0.5 to 1 gram per kilogram over 2 hours. Where you give IVIG, it does take a little while to act. So if the bilirubin doesn't continue rising, if it is touching the exchange also, you can wait unless the baby is neurologically symptomatic, and the dose can be repeated in 12 hours. However, you need to keep continuing the 2-hourly repeat as long as the bilirubin stays high. An urgent exchange should be performed for infants with signs of intermediate or advanced stages of acute bilirubin encephalopathy like hypertonia, arching, retrocolis, opisthotonus, high-pitched cry, or recurrent apnea. So sometimes it's not clear-cut, but where in doubt, better to do exchange if it's approaching the level, and you may do it even at a slightly lower level if the baby is having signs of kernicterus. Sometimes they may present to you beyond the peak, and you may not see the high level, but the baby is having features of kernicterus. You still have to rush to do an exchange in any neurologically abnormal baby with a high level of jaundice, which potentially is bilirubin neurotoxicity. An urgent exchange should be performed for infants if the TSB is at or above the exchange as well. If you repeat the blood test while you're waiting for the blood to be ready and it starts reducing and the baby doesn't have features of encephalopathy, then the exchange may be deferred. Continue intensive phototherapy and follow the TSB every 2 hours until it's below the escalation of care threshold. Cross-matched washed packed red blood cells mixed with thawed fresh frozen plasma. So the blood group you choose depends on the condition you're treating, and the hematocrit approaching 40% is preferred, as we discussed earlier. The additional albumin containing fresh frozen plasma will help in keeping the hematocrit close to 40% and also augment the bilirubin removal. Bilirubin albumin ratio is not being routinely used, but obviously it can be a useful guide, and that's what this guideline is adding. It can be used in conjunction with the bilirubin level to determine the need for exchange transfusion. So the bilirubin to albumin ratio treatment threshold for exchange, measured as a TSB in milligrams percent divided by serum albumin in grams per deciliter, varies by gestational age and risk. More than 8 if the gestational age is more than 38 weeks and no neurotoxicity risk. More than 7.2 if over 38 weeks and 1 risk factor. More than 7.2 if gestational age is 35 to 37 weeks with no risk factor, and more than 6.8 if gestational age is 35 through 37 weeks with at least 1 neurotoxicity risk factor. So this is not hard to remember these 4 numbers: 6.8, 7.2 and 8, 3 numbers rather. So the last part is about the follow-up, timing of follow-up after discharge. We know that the Bhutanese charts were used on their own, but now the revision is that you correlate with how far below the phototherapy the baby is. So it's more easy, more clear-cut to follow. And you don't need an additional chart, you just need the phototherapy chart for the age of the baby. So the current guideline recommends using the difference between bilirubin concentration and the phototherapy threshold at the time of measurement to determine the interval between discharge and follow-up and the need for additional TSB or TCB. Other considerations that would influence the timing of follow-up include the risk factors for rebound, as we discussed before, the gestational age, postnatal age, assessment of the breastfeeding, weight loss from the birth weight, and assessment of well-being of the infant and the parents. So all these would play a role in your decision making. Suppose the jaundice is not that high, but the weight loss is high and the breastfeeding isn't established, it would still benefit them to come earlier. And of course, the weight loss and the poor feeding is a risk for the jaundice to rise as well. So the chart which we will show next is only applicable for infants at least 12 hours after birth and for the infants who have not received phototherapy before discharge. So if they have received phototherapy, you would follow the risk factor for rebound that we discussed before. And you would need to repeat 6 to 12 hours after they stop phototherapy. Any infant discharged before 12 hours should have a follow bilirubin measure between 24 and 48 hours of age. So the earlier they go, the earlier you bring them back for the follow-up. So this is the chart which is very helpful. So the starting point is more than 12 hours old with the TCB or TSB measured. Determine the hour-specific phototherapy threshold based on gestational age and the presence of a known neurotoxicity risk factor. Measure the TSB if the TCB exceeds 3 milligrams percent below the phototherapy treatment threshold, or if it is more than or equal to 15. So all this is what we discussed earlier. If the bilirubin is at or above the phototherapy level, obviously you would begin phototherapy and follow the guideline. If it doesn't meet the phototherapy, then if it is within 2 milligrams of the phototherapy threshold and the age is less than 24 hours, you would delay discharge, consider treating these babies and measure in 4 to 8 hours. If the age is more than 24 hours, you consider repeating at 4 to 24 hours. Whether you measure at 4 hours or by the 24 hours depends on whether they are going home or whether they are observed in the hospital. And you could also consider delaying discharge and consider phototherapy, and discharge with home if that is an option, home phototherapy. And if you discharge without phototherapy, you should be closely following up these babies. If bilirubin is between 2 to 3.4 milligrams, regardless of the age or discharge, review them by 24 hours. And 3.5 to 5.5, regardless of the age, you review them in 1 to 2 days. And 5.5 to 7, if they are discharged less than 72 hours, follow up within 2 days. TCB can be used also. If it stays below the cutoff that we mentioned earlier, you can continue to monitor the TCB. And discharging more than or equal to 72 hours, clinical judgment can be used. Suppose you have seen these babies more than once in the clinic and the trend is definitely coming down. Even if the bilirubin is high, you don't need to keep seeing them. You bring them back around 2 weeks to 3 weeks of age, as we discussed earlier, to look for conjugated jaundice, and follow the newborn screening result in these babies as well. If it is more than 7 milligrams per cent below the phototherapy threshold and they are discharging less than 72 hours, you bring them back within 3 days. And more than 72 hours, already their risk is very low, so you can bring them back 3 to 4 days or whatever. So usually we bring them back maximum 3 to 4 days after discharge, even if they are very low risk, just to make sure the other parameters are going well. It's also very important that the hospitals have a clear policy to monitor bilirubinemia, because this is a medico-legal risk. We owe to the parents and the family to make sure all the treatments are done according to guidelines, and clinicians should document the activities specifically related in the medical record. All facilities treating infants should have necessary equipment of good quality and regularly checked to provide intensive phototherapy. The last part is about parent education and information we give them at discharge. So before discharge, all families should receive written and verbal education about neonatal jaundice. Parents should be provided written information to facilitate post-discharge care, including the date, time, and place of follow-up. It's very important that they understand the risk. We should be telling them the risk to the brain, which can be permanent, and all parents would understand that. Again, a word of caution about sunlight. If the parents do believe in it, tell them it doesn't do much and you shouldn't rely on that. The follow-up time is irrespective of whether they show any sunlight or not. And in case they go to another center for follow-up, we should be clearly giving them the birth hospitalization information, including the last TCB or TSB, the age at which it was measured, and the Coombs test and blood group, if any, in the discharge summary with the clear instructions as above. So to conclude, the revision of the guidelines is a very welcome change. It's comprehensive, it's fairly baby friendly. I would say they're trying to minimize the interventions as far as they can. They are suggesting less blood tests if you can monitor the trend of TCB. They are suggesting home phototherapy in certain situations. They have increased the threshold for treatment. They are suggesting intensive phototherapy in all situations to shorten the duration of phototherapy. So I'm very happy with the changes. Most of these are already practiced in my routine practice, what we discussed before in the earlier videos as well. And we try to minimize the interventions, family and breastfeeding friendly, and there is a clear allocation of responsibility to the clinical team, so there is no room for error. So I know it's a bit lengthy and I hope it's useful. Thank you.